I never introduce people, but I always let people. Nancy, so who are you and what are you doing here?
So I'm Nancy Davenport Ennis, and I'm actually a cancer survivor, Bill, 22 years. My husband is a 10-year cancer survivor of stage 4 cancer. I started the Patient Advocate Foundation and the National Patient Advocate Foundation in 1996, and our mission is to remove obstacles from access to health care, both at the immediate level of the patient, one-on-one through Patient Advocate Foundation, as well as at the federal and legislative areas through National Patient Advocate Foundation. So I'm a patient advocate.
Terrific, thank you. Jackie?
Hi, I'm Jackie Dory with Lilly. Is my mic on?
Yes, it is.
Okay.
I can tell.
So I've been with Lilly for almost 10 years, worked in our corporate affairs function and global public policy, and for the last 5 years I've been in our oncology business unit. Happy to be here.
Great, it's good to have you here. John?
Good morning, my name is John Fox. I'm a Senior Medical Director at Priority Health. We're in a health plan headquartered in Michigan. We're part of an integrated delivery system, so in my job I get to see both sides of the fence, the payer side as well as the provider side.
And so you're a not-for-profit, right?
We try to be.
Okay, you're trying to. Key point there. All right. Okay, that's gonna. And how many members do you have down there?
We have
or
about
up there?
650,000 covered lives in both commercial products, Medicare and Medicaid.
Okay. And did you go to medical school or internship and residency close to here, or?
Yes, in fact I did. I trained in Baltimore. And,
Okay.
We'll have conversations afterwards, Paul.
All right. So it's amazing how I know all this stuff. Paul. Doctor.
Hello, my name is Paul Solano. I'm a medical oncologist at a community hospital in Baltimore, GBMC. I'm also president of the Maryland, D.C. Society of Clinical Oncology, statewide oncology association affiliated with ASCO.
Terrific. Thank you. And just a little bit about myself. Christian was too brief. I'm just kidding. But
We've only got an hour.
I know. We only have right. Good point. But anyway, so. I was CEO of NCCN from 97 to 2011. Before that, I was Vice President for Clinical and Coverage Policy at Aetna. So I've kind of been on a number of different sides. So let's start off. I'm going to focus, as I said, on where's the value in cancer care. So we're going to start with you, John. And you're a physician. You're a medical director. You work for a not-for-profit managed care company. And I emphasize managed care company because in my mind, I'll be editorial here, there's no such thing really as a health insurance company anymore. But as a managed care company, I'm looking for, in a major entity, I'm speaking about the industry, not so much about Priority Health, but on your front page, your homepage, your website, you say, we seek to improve the the lives and health of our members. So with that statement there, what benefit or value do you bring to cancer care?
Fair question. Well, let me give you the full sentence because we seek to improve the health and lives of our members by providing access to high quality and affordable health care. So It kind of runs the gamut between improving health but also doing so in an affordable way. So the question is, how do we do that as a health plan? I think our mission is to ensure that we do provide access to high quality and affordable health care in our communities. And by doing that, we need to do that in partnership with providers. And we're part of an alliance of community health plans, just as this is an association of community cancer centers. And we work with other health plans in the country like Geisinger and Kaiser Permanente, Tufts, and others to develop innovative programs. So we've got a program in our community, we call it the Oncology Medical Home Project, where we're seeking to find new methods of paying for health services, especially cancer care, as well as transforming how cancer care is delivered. And I would say that the things that we're really focused on are trying to eliminate waste. And in the previous conversations, we talked about how do we avoid hospitalizations and ER visits. But probably the biggest opportunity, and this was referenced in the previous conversation too, is how do we make sure that patients get the care that they want? I can't care what care patients receive, but I can certainly care that they receive, that they understand their options and what they're likely to get from those.
So the care that they want, did you mean that? I know.
Yeah.
So did you mean that, or that just kind of, okay.
And there are lots of good examples. There was a CanCore study, a survey done in 2012 published by Janice Weeks that showed that 81% of patients who were getting chemotherapy for metastatic colorectal cancer thought they were getting curative chemotherapy, and 69% of patients who were getting chemotherapy for metastatic incurable lung cancer thought they were getting curative chemotherapy. So that's an example of we need to ensure that patients understand what their treatment options are and that the care they're getting meets those needs. And there are also other examples where patients are getting chemotherapy because that's what they thought they should get, because that's what their doctor thought told them they should get, when in fact they were perfectly happy with other alternatives that were less expensive. And so it's not about the cost of the therapy, it's about trying to align the treatment that patients get with their priorities and their preferences.
So just one point, I won't belabor this, we'll come back to it, but so I just saw a survey last week that surveyed, I forget what the number of patients was, but it asked the question of, as a patient with a diagnosed cancer specifically, which of the two options do you prefer? One, a 50% chance of living for 6 months, or two, a 20% chance of living, 2 years? And 78% chose the 2 years, which is just, it wasn't overly surprising, but it's going to get into the question of how do you value technologies and their impact on length of life? So actually I'm going to go a little out of order that I had set. So Nancy, talk to me, 2-time cancer survivor, your husband Jack is 10 years cancer-free. What benefit or value do you, as a patient advocate and as a patient, do you even think of value? Should patients think of value when they're thinking of their cancer treatment planning?
So I think for patients, the word value has a number of different meanings. And I think we have to really begin there. I think patients today understand that more and more when they come in and meet with those of you who are in this audience and you're talking with them, whether you're the nurse or whether you're the business manager in the office or whether you're the physician, you're trying to talk with them about the options that they have. And then you have to move to that financial discussion today of what are your responsibilities within these different options. And so Bill, what we're seeing more and more are the patients who are wanting to have open dialogue with physicians. They want to know what the options are to them, but just as immediately they want to know, how am I going to pay for this? And how does this happen for me? And what is the value of my life going to be if I agree to this therapy? And that is defined very often by the decade in which they are living. So when we're working with a 29-year-old man like Jonathan, who was diagnosed with a very rare pediatric brain tumor, and we were able to go to an institution that provided a pediatric protocol for him in his own state of residence, which was across the country. For Jonathan, value was in getting to the clinical trial that would give him the likelihood of the longest life to be dad to his 2 young children and husband to his wife, Tanya. So depending upon the decade of life, depending upon the financial circumstance of the family, and often even the geographic location of the family, value has a very different definition.
So, I heard you say the value almost seemed like an intermediate outcome in the sense that, the value was getting to be in a clinical trial, so ostensibly the individual would have a higher probability of living longer for his children. So to me, that was just kind of an intermediate step. The real thing that we look for is the outcome of living longer specifically.
You're right. However, there are often patients, such as Jonathan, who know with collaboration with their physicians that a long natural life is not going to be in their future. And for those patients, their definition of value is, what is the therapeutic intervention that I need today that is going to give me the highest degree of quality of life for the longest period of time? For our young friend Holden, who was 8 years old, Bill, at the time of his diagnosis, there was a promise if he could get to the right surgical intervention that his brain tumor could be managed and that this 8-year-old had the hope of a natural and normal life. Today, Holden is 17 years old, deciding which college he will be going to. for that family, value was all about not only quality of life at that time, but claiming that long-term life that was his promise in the future.
That's a great thing. Good. So Dr. Solano, Paul, so I'm going to have two questions for you. One is going to be, when you're sitting across the table from that patient, with caregiver usually, what are you offering them? You offering outcome or value? I mean, what are you talking about, and what should you be considering? And then I want you to respond. It's a study, and it's Jane Weeks. I know, God rest her soul. So, are you making sure that patients understand what the probability or likelihood of specific outcomes are, given if they're given chemotherapy and metastatic colorectal cancer? So, two questions there.
Well, in determining value to a patient, you really need to be thinking about three different factors. And I'm just going to break it down to clinical benefit, toxicity of treatment, and then cost. Now, those are very broad categories. And really, the first, before you get into any of that, you really need to sit down with this patient and the family and have them truly understand what their illness is and what their expectations are, particularly as it relates to the natural history of what we would expect. There is, as an example, with someone with colorectal cancer, we know that those patients, none of those patients are cured. And it's important that they understand that everything, this whole discussion is being done in the framework of the fact that a patient with metastatic colon cancer is not going to be cured, meaning free of their disease. On the other side of that, there have been lots of advances and lots of therapies to talk about. When I started in my training, there was probably one or two things to talk about. Now there's 8 or 9 things to talk about, and particularly as it relates to individual patients. There's many, we haven't touched on this, the idea of personalized medicine, of the idea of genetically evaluating a patient's tumor, such as in colon cancer, the RAS gene mutation has a very important factor. So this is something, though, that requires that the patient understand what their overall outlook is, but also what their individual situation is, so that then you can then begin to frame to them exactly what you can expect. Then you're into the vagaries of you can talk about percentages, but percentages, as I've told many, many patients, the statistics are what we talk about when we talk about hundreds or thousands of people, not about them. Because for that individual, and as I'll give an example of a patient of mine with metastatic colon cancer that is works at the docks in Baltimore, who's had liver and lung metastasis now for pushing 10 years, that this patient clearly has benefited from many of the interventions we've done. He's raising his family and his grandkids. I have other patients who haven't been so lucky. So what I don't know with it when I'm sitting across the patient, really the future, although we sometimes are invited to tell people the future.
And patients, I always maintain, they all see themselves in that upper quartile. That's why I use that example.
Right.
But let me ask you a loaded question, as most of my questions are. So, do you think that you should have to be talking about cost to someone that was just diagnosed with metastatic colon cancer?
Do I?
I mean, how do you interpret the
Right, because
cost in the language?
because I dodged your question about cost.
You did. That's why I asked.
Yeah,
Follow-up.
and because that's another issue about what is really the cost. Because as I'm sitting there not knowing about their cancer, about their future, what their toxicities and side effects are, you think I know what their insurance really is saying and what they're actually
But
out of.
and let me ask the question. It's not should you not. Do you think that you should have to sit there at that point in time and talk about costs, or even at the next visit with your patient?
I think it should be part of a conversation. But all of these things, like these are complicated discussions. And if someone had said, should this happen in the first 50 minutes of my meeting of this patient, I would probably say absolutely not. Should it happen at some point as we go through this process? Because I look at these things, I don't ask for patients. This isn't like, this is it, one deal, take it or leave it. This is a process that we're working with patients. And part of that process, frankly, is financial. It is financial as we talk about the various health plans and what their levels of care are. So that is part of it.
Okay.
But is it part of that initial conversation? I will say no.
Okay, great. So Jackie, you know, your industry's in the news, almost rivaling managed care these days in terms of being in the news. And obviously looking at the costs of drugs and biologics for the management, treatment of cancer care, let me be specific. So just from we're going to talk value here. And let me define value. Sorry to be somewhat a little hubris here, but, you know, value to me is the patient benefit / outcome derived from the expenditure of a specific number of dollars, okay? I tell people this, you know, as a consultant, they say, Bill, you're supposed to follow those white papers that say we need 5 commissions to figure out what value is. But anyway, so the whole issue of value, you know, bringing patient benefit, obviously, for a specified amount of healthcare expenditure. So how is the value that you bring, because you're bringing a productive, positive thing to market, how is that value distributed across society, patients, Eli Lilly and Company?
Well, first I have the benefit of going last with this question, so I can identify some synergies between the answers of my peers up here. I think first it's important to recognize that value, like beauty, is in the eye of the beholder, right? So perception is reality. How you feel is very individual and very unique to you. So when you think of medicines and how medicines make you feel, I think you have to look at it both from the societal benefit, like you said, Bill, as well as from the economic benefit. So from the societal benefit, you look at the quality of life, and that's very individual to you, so patient-reported outcomes. And then you also look at, you know, does this medicine increase the length of life? So that's important from the societal perspective. And then from the economic perspective, you know, you look at how does this medicine help this individual increase their productivity, engaging in society. So I think if you look at it from those two perspectives, that's helpful, but it's challenging, right? Because it's very, very unique to you. I would say one part of your question was distributing throughout Lilly.
To Lilly, society, the patient.
Right,
so
right.
How does it get distributed? In terms
How
of,
does
say,
value-
dollars, I mean, how does the value get distributed? Does society get 90%, Lilly 10%, and just from almost a dollars perspective? I mean, how does that break down, you think?
Well, I mean, I can share that, and I think that this is, you know, common among industry peers, but Lilly in particular reinvests 20% of its revenue back into R&D. So when you look at, you know, trying to make life better, the medicines of today are funding the medicines of the future. So I think that's an important point to make.
Okay, terrific. So let's now get to so I've done my philosophical thing, which I think is important. We're going to come back to it. I'm not done with philosophy. So, see, actually, I'm getting old and cantankerous. I'm going to be eligible for Social Security in 11 days. But anyway. So, whatever that means or says about me. But, so let's talk about the elephant in the room. And for today, I'm going to name it Waxman. You know, Waxman sent a letter last week to a company in his own state complaining about the price of drugs specifically. So let me ask the question, John, of you first. So in terms of increase in benefit from healthcare technologies, drugs, devices, procedures, and techniques, and biologics, I need to throw in there, is the increase in benefit that we're seeing kind of across the board in treating cancer keeping up with the increase in the expenditures of dollars, in your mind?
I think of things relatively. When I look at the expenditures for cancer care, especially end-of-life cancer care, compared to what we invest in other chronic illnesses such as rheumatoid arthritis or COPD or heart failure, there is a dramatic difference between what we invest in the end-of-life care in cancer and those other chronic illnesses. It's not my position as a payer to say whether or not that's a good value or not. But I think what we really have to evaluate is, are we applying the right resources to the right patient? Are those patients likely to benefit? Do they understand they're likely to benefit? Is that investment consistent with their goals and preferences and priorities? And interestingly, and I'd be interested in any of the other panelists' perceptions of this, sometimes patients do things because that's what they think their doctor wants them to do. Sometimes they think patients do things because that's what they think their family wants to do. Sometimes families want patients to do things because that's what they think the patient wants. And it's really until we have a very heartfelt conversation that we discover what priorities and preferences are. And I would say that if we're investing in $100,000 to prolong somebody's life by 2 months, but that's not what the patient wanted, that's a waste.
So let me, and I think actually on end of life we could actually reach consensus across various stakeholders. But let me bring it back, let me ask the question more specifically. I always wanted to go to law school. So with respect to, is the benefit that can be accrued by patients with first line and second line therapy in the metastatic setting, is the increase in that benefit keeping up with the increase in costs, in your mind? Or in your mind and the industry's mind?
I think in the industry's mind, I would say no. The rise in costs is out of proportion to the increase in benefit.
Okay.
When we look at spending $100,000 for 4 months of additional overall life expectancy, that seems out of proportion compared to what we pay in any other chronic illness or acute illness for that matter.
Okay, so Dr. Solano, Paul, you know, and I've worked at the AMA before Aetna. I've always hated the term. I don't know whether it's because I was an AMA provider, but anyway, as a clinician, what's your view in terms of your ability to offer, you know, patients benefits specifically compared to what the rate of rise in costs has been, say, over the last 10 years? I mean, how do you see it?
Well, there's no question that the rate of costs of cancer care have risen exponentially over the last 10 years. I'll refer people to the thing put out recently, Cancer Care in America by ASCO, and it has a nice graph here of the cost of monthly cancer care. So in 1980, it cost about $100 a month, and now the median cost is up to $10,000 a month. This is on the web. So that the cost is going to, now I don't think anyone thinks that the survival advantage or progression-free survival or clinical benefit has increased by that degree in the last 20 years or 30 years. So we all understand that the costs of care have gone up, particularly as it relates to drugs, but other things that we do has gone up well beyond anything that we see, you know, on average. Now, for certain individuals, these drugs have been miracles. You know, there are many diseases, chronic myelogenous leukemia is an example, multiple myeloma, certain forms of breast cancer, of lung cancer, where these costs certainly are extremely justified. But these costs are considerable. And I will say, as a clinician, because we're seeing across from the patient, and I view myself first and foremost as an advocate for my patient. What is the best thing for them to do? What are their wishes? What are they're making sure that they understand what they have and what their options are and what their toxicities are. But on top of this, we are presented with an explosion of new therapies that have been approved by the FDA, that have been sanctioned by organizations like your old organization, the NCCN, that we are obligated to talk and discuss. So these conversations have become very complicated, and when someone wants to throw cost into the equation, we can say, oh my, this is so expensive. But in the end, you know, we're really trying to relate all of this information so our patients can begin to make a decision. But it is, I will say, as a practicing doctor, no one's ever asked me what the cost of any drug is. It is what it is. Now, it's not up to me to determine what it is. It is. And then we have to then deal with it with our patients.
Okay. So actually I'm going to shift and ask you a technical question I know you can handle as well as anybody. What I was getting at with Dr. Fox was, you know, when we answer a question and move to end-of-life care, which is a critical issue, and actually, as I said, I think one we can all probably agree on. Well, I don't know. A lot of us, let me put it that way, agree on. But, you know, watching England, it actually gives us a little hope because I think they're more schizophrenic than we are over there in terms of their system. They have the National Institute for Health and Clinical Excellence, you know, amazingly well, amazingly from my perspective, named NICE. And NICE basically, they just have approved 2 drugs, but in the space of the 18 months before, actually turned down 12 straight oncologic agents in terms of recommending to the government that they be covered in the United Kingdom. And then is it Cameron? Prime Minister Cameron kind of came in and he set up the Cancer Drug Fund to pay for all these drugs that his other government body doesn't want to pay for. And now they have the Terminal Illness Program, which says if you have a year or less of life, you get not everything paid for, but special consideration. But they have a process over there, you know, cost utility analysis and cost effectiveness analysis. Without getting too technical, you know, and I kind of look at these things, without getting too technical, this is why I asked the question. It seems like there's a negative bias when drugs and biologics, potentially devices, come on the marketplace, because particularly drugs and biologics, the indication usually is for a 2nd line or 3rd line therapy, so you have more resistant patients, et cetera. And that's why I'm so intrigued by that when I heard that answer to that question about, you know, 78% see themselves really in that upper quartile. I mean, how should we formally do this? Because I think to a certain extent, you know, this is coming to the United States. But how, from a patient advocacy perspective, should this type of analysis be done? And what are the implications for the availability of new drugs?
So I think we have to be reminded as a nation, and certainly everyone in this audience lives this every day, that the way we have come to a point where we can offer added years of life in treating cancer is through progressive, innovative, therapeutic interventions. Our nation, Bill, is at a really interesting time in its history, where at this point there needs to be the marriage of personalized medicine and the integration into that field with the very traditional therapies that have been here for so long. And as with any transformative event in the country, it is going to take dollars to fuel the transition from a more traditional type of therapeutic intervention where you say, I think this will work, let's prescribe this, to let's get you to the lab, let's do some testing, and let's come back and have a concrete determination of what is most likely to work for you with this disease based on the information that we have. So that being said, our nation is beginning to develop a number of new proposals that are shaping how we are paying for new, innovative, progressive therapies. We see higher and higher regulatory burden on new drugs that are coming to market around reimbursement. We see new reimbursement schemas that Kavita talked about earlier today that involve bundling. And when you start trying to bundle the cost of a new agent, it's almost virtually impossible to do that in cancer because we don't know where the parenthesis begins and we don't know where the parenthesis ends in that area.
Can I ask you an expert question, just so I still have it? Do you think bundled payments or pay for performance, and I'm deviating a little bit, but I'm going to go probably to John next, are actually going to see the light of day out of the context of a pilot project?
So it's a good question. And I think the physicians in this audience are going to have a great opportunity to influence the answer to that question. Because to the extent our physicians do not move in the field of oncology into medical homes, which if Ted Ocon were on this dais, he would tell you it is extremely difficult to get the oncology practices into a medical home. So it's very difficult, Bill, at this point to answer the question from the perspective we're still in transition, and what we see our physicians doing is for survival, they're selling practices into hospitals to be assured they're still there to treat their patients. So we have to stabilize the hemorrhaging that's happening in this transformative process, and we have to build a platform of security for our physicians. We failed to do that at midnight last night. And until we address that, Bill,
Yep.
I think we're going to continue to see flux in the industry, and the patient is going to be caught in the crossfire.
So I'm going to move to John because, I mean, I want to, you know, and you're as good as anybody. I mean, you're involved in all these issues, and you seriously are recognized as a national expert. And I raised, you know, my first comment here was we are in a huge pilot project here. we don't seem to be moving out. You know, we've been in transition. My 30 years in healthcare, my wife would say, yeah, you've been in transition longer than that. But it's an aside. Sorry. But anyway, but what's your view? Because, you know, to me, I look at COA's proposal, I look at ASCO's proposal, and it's like they want episode-based payments, they want pay for performance, they want to get you know, rewarded just for using guidelines, et cetera, et cetera. So, I mean, everybody wants everything. So where are we going to happen? What's going to happen?
I think there will be the ability to have.
Do you have a crystal ball?
You get the easy
I
question.
could retire. I forgot this answer. I think there's possibility of bundles around surgery, around radiation, but I think there's possibility around bundles for paying for care itself. But I think it's extraordinarily challenging to put providers in a position of making financial decisions and care decisions simultaneously. If we could create a system where providers weren't accountable for the cost of drugs, given the extraordinary variation in the cost of therapies, not even in individual drug, but in polytherapies, I think that might work. In our oncology medical home initiative, we held providers accountable for a lot of things, but not the cost of drugs. I think oncology drugs will be the last bastion of fee-for-service.
Okay. And we could go on. Yes.
Can I just chime in really quick? I think the reason we're seeing it as pilots, right, is because I don't think there's a one-size-fits-all approach to this. So I think you're going to continue to see everything being piloted because every practice is different, every patient is different. And so I don't think we'll see, you know, something come forth that's going to replace what we currently have. I think we'll see lots of different things. I think we'll see accountable care organizations. I think we'll see bundling. I think we'll see medical home. I think we'll see pay for performance kind of all blended together because I don't think there's a one-size-fits-all approach.
I do think, though, that for as much as we talk about pay for value in our relationships between providers and payers like Priority Health, I think we also need to have some accountability amongst manufacturers as well. They get their dollars up front, and as long as the drug's administered, you retain your value without any risk. And I think in the future we need to look at different systems where instead of just simply paying for a drug, we pay manufacturers, whether it be of a drug or a device, for the outcomes as well. Because today I don't think there is any mutual accountability. I think with genomics and genetic testing and the ability to provide personalized medicine, we're getting closer to identifying those patients who are most likely to benefit. But if we don't derive the 10 months of overall survival that is portrayed in these trials, should society, should the payer, should the patient be compensated because the drugs or devices didn't deliver the value that was projected?
So you two have just like set up the panels for the next 5 years, and but I think, I mean, seriously, what I want to do quickly is I want to ask you about cost utility, cost effectiveness analysis, because I know Louie's doing a lot about innovation, but then I just want to come back, and I'm going to leave this side, don't think I've forgotten about you, and just ask you to give a 60-second answer, John, about whether or not you see risk sharing between biopharma companies and managed care companies becoming a major pilot project in the next 3 years. So, Jackie, with respect to, you know, how does your company view kind of like the application of cost utility or cost effectiveness analysis at approval or any other place? And what's your view?
Yeah. Well, you just hit the nail on the head at approval, right? So it's very challenging, especially in oncology, because often when we're launching a medicine, I don't know that we fully understand what the potential of that medicine is in the market. Especially in cancer, because there's other tumor types that we're studying it in, and so it takes time. It takes time to understand that full value proposition. And you can go back and look at it in time retrospectively and conduct a cost effectiveness analysis then, but I don't know that you can do that successfully at launch because you don't know yet.
Okay, great. So John, 60 seconds. Risk sharing, I mean, it's interesting. You have it in England, you have also in Europe as well. All sorts of deals being done. You know, if this patient doesn't hit you know, this specific outcome, then we'll rebate you the price for the drug, blah, 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 blah.
Yeah.
Is that going to happen with you? You're going to be first in the country.
I'm trying to be.
Okay, good.
I think there are a number of challenges, though. In any risk-sharing arrangement, you need clear parameters. And probably the easiest parameter to measure in cancer care is death. That's rather incontrovertible. Measuring progression-free survival or response rate, complete or partial remission, there are challenges there. But I think there's a lot of interest amongst pharma to be able to demonstrate something beyond just that they provided a drug. So I think we will find opportunities where there will be risk sharing, where pharma will compensate us if their drug doesn't deliver the value, the overall survival, or the progression-free survival, whatever we can agree we can measure, if their drugs don't deliver that for a population of patients. I think it's difficult to measure that for an individual patient because there's such variability. But if there are a population of patients where we don't hit the target of 10 months of overall survival, then the drug doesn't deliver the value that was portrayed when the drug came to market.
In your agreement.
So Bill, I'd like to ask.
I'm going to come right back to you. I need a one-word answer specifically. So, if a drug, and this is for all you pharma folks out there, if a company did a deal with you, would you expect that deal to be done for every other drug in their portfolio in oncology? Yes or no?
No.
Okay.
And Bill, I got to take the other side of that to ask, and this really is on behalf of patients and the pharmaceutical biotechnology industry that's willing to go to bat in the field of innovation. So let's say that pharma bios take that deal, and let's say that they actually deliver what they delivered to my husband, who was a stage 4 patient, given no more than a 30% chance to live 120 days. But due to innovation and innovative therapeutics, we were able to save his life, and 10 years later celebrate the contributions he's made to society. So the question becomes, would you pay them more when they hit home runs for a population that are truly making a major difference? And it's not meant to be a difficult question for you, because I respect what you do. But there has to be that balance. They're taking the risk, the patient is taking the risk. And so when we hit those home runs, whether it's a Gleevec or whether it's a new CML or whatever that is, where's the payback to those innovators?
I think the dilemma, though, is that we can't look at individual patients. We have to look at populations of patients, because there will be outliers on both sides, those that get one dose of the drug and die tomorrow, and those that live 10 years.
Right.
But I appreciate your point. But I think the challenge is right now is that the amount that we invest in hope, especially in end-stage cancer patients, is way out of proportion to what we're willing to invest in diabetes care or COPD, and the morbidity and mortality associated with those illnesses is far greater than cancer. And for some reason, we as a society place a greater value, and I can't use your term, but place a greater value on cancer care because we're willing to pay extraordinarily more for patients with cancer than any other disease.
Okay. Yes,
Right. One of the things, the other part of this equation is we're talking about the cost of drugs but in a little bit this is a skew of our sort of reimbursement system, because our reimbursement system is very much focused on tests and procedures and hospitalizations and equipment. But where we don't really fall down is in the conversations we need to be having with our patients. And I think it goes to your point, John, because sometimes we wouldn't be spending these kinds of money on people if we really had time to explain and were properly reimbursed to take care of these patients and truly explain this to people. I think that's what's getting lost. And right now, with the sort of amount of things, whether it's regulatory things, the cost of running a practice, we're just being overwhelmed. But we all think, someone brought up the issue, well, we can farm this out to a nurse navigator or this person, that. But sometimes these conversations are extraordinarily complicated and need a lot of time. And for the amount of reimbursements being given to a physician or a nurse practitioner is paltry compared to any drug I could write for. And this is like, the system is really out of whack. And I think if we had these better conversations, I think our patients would better understand what they have, and they would make better choices, and probably less expensive choices than the things that we're talking about.
So I couldn't agree with you more.
Yeah.
One of the things I didn't share when I introduced myself was I am a cancer survivor. And so from the patient perspective, knowledge is power. And so I think you have to figure out a way to incentivize that behavior at the physician level so that they have those conversations with their patients. Because when you're diagnosed with cancer, it's a whirlwind. and you're looking to a single point of care, you're looking to your physician to provide that expertise and to share what your options are, all of your options. And that's just an invaluable conversation.
Yeah.
I absolutely agree
And
with
I think
you.
that's the importance of partnerships. In the work that we've done with cancer providers in our community, we've recognized that we're paying for the wrong things. They're relying on the margins on their drugs to pay for all the things that they do that they don't get compensated for. So we now pay for advanced care planning, whether it be done by a physician or a social worker or a nurse or the pharmacist even. We also pay, Linda Bosserman at US Oncology developed a treatment planning codes that we now reimburse oncologists for. But you're absolutely right. The things that we should value the most, which is that conversation, is the thing we reimburse the least. And if we don't right-size that and create alignment, it won't happen.
And that, you know, in Michigan, in healthcare, I say, especially the relationship between clinicians and payers seems to be, you know, a separate country. I mean, the relationships are so good. Just real
it's
quick.
Those cold winters.
I don't know. Yeah, you got coalesce there. I don't know. Have big fires or whatever you do up there. But anyway, but do you think the rest of the industry, all the big ones, the WellPoints, the Aetnas, the Uniteds, the Humanas, are they willing to think like that and pay Dr. Solano on behalf of their beneficiaries to have those conversations?
I think we all recognize that there's a lot of unnecessary cost throughout healthcare, not just in cancer, because we don't invest the time in those conversations. That's the purpose of the medical homes, I think. So I think, yes, other payers are willing to invest in that if they realize that it changes outcomes.
Okay, great. So last question. So think about comments, whatever, and please, everybody, I want everybody to weigh in on this, because you can read my book next year, On the Road to Kick-Ass Healthcare. It's the title. Come on, it took a lot of... I don't have time to tell the story, but that's the actual title. Actually, this was years ago. I was on a panel like this, and I was introduced. It was 8 o'clock in the morning. I'm half asleep, gotten in late, and the next panelist they introduced from U.S. Healthcare, which eventually became my bosses at Aetna. But anyway, U.S. Healthcare, and the moderator said, U.S. Healthcare, better known as the kick-ass healthcare company. I'm like, wow, that just doesn't seem to be the right direction to be going in. But anyway, so I was recruited as this, I almost said lame brain, but book-learned PhD type from the American Medical Association to set up a tech assessment program and run national coverage policy. At the time, Aetna was the second largest, now they're the third largest health insurer, I guess we can call them back then. And being Catholic, I came in with 5 commandments, and they were all from books, you know, and things like that. When I left, I had 2 more commandments. One was, make sure the processes that you put in place to make decisions, coverage or individual, are ones that you would use for your mother, your brother, your sister, your daughter, etc. And secondly, in close calls, always err on the side of the patients. Now, obviously, I'm very good at stating the obvious, but, I mean, I learned that through experience after experience. And so, John, I mean, tough question. When you, I mean, and again, you're a forward thinker. We need, you know, some of the tough, we need a kick-ass healthcare company up here, but when you're setting up your policies, I mean, do you think like that this process could be the one that makes a decision for my wife, or my brother, my sister, etc., and know what the decision at the end would be? And do you think you should think like that? Because at the end, I thought I should think like that.
Yeah. I think we all have a variety of constituencies and stakeholders that we have to please. But I think at the end of the day, as a community-based health plan, we're in this for the long haul. We're in our community because we want to see the community thrive and we want to see it prosperous. And to do that, we need good quality health care. And I don't think that being single-minded around profits will allow us to do that. Again, our mission statement, which you cited early on, is one we live by. But I think there's an extraordinary pressure amongst employers to contain healthcare costs. And I think we have to recognize that the burden of cancer is borne not just by individuals. And it's not borne just by individuals and their families, it's borne by society, as is the cost of all healthcare. And unless we can reach some mutual accommodation where we're balancing the patient experience, we're balancing healthcare outcomes, and we're balancing costs, we'll continue to underinvest in other things that we really value, like our schools and our communities and our parks and recreation. And I think that's the real challenge that we have, is how do we right-size this investment so that we get value for our society as a whole and not just an individual.
Okay, I mean, you're right, and I guess I could close that. But Dr. Solano, from your relationship with payers in Maryland, from a reimbursement standpoint, it's kind of a different state, I understand. But do you think payers kind of think about that? That, you know, the medical directors and the processes that you see, that if, I'll tell you why. I never got a call from the executive office at Aetna that ever asked me, what's the best place in our network to go get treated for multiple myeloma? Was what's the best place, period. We don't care about the network. We don't care about your stupid coverage policy down there. I'm exaggerating a little bit, but yeah. So how do you see that? And then I'm going to close with Nancy, and I can't see anybody out there, but if somebody has a question, we'll go to them, or a comment.
Well, one of the things, maybe this is a little off your subject here, but I think that we haven't touched on research. I guess we talked a little bit. But and you mentioned, are we in this world a constant pilot project? Well, I'm from an experimental background from my original training, and I'm okay with being in a pilot project. I don't mind being in a pilot project, and I think our patients, the payers, everyone needs to understand that we need to be doing research. I really would want insurance carriers to be much more open to coverage under clinical trials, to make that process more easier. That our federal government is starting to tighten its belt with regard to clinical trials on all aspects, and I think that's an important part of the care of patients for the future.
Yeah, and the good news is under ACA, clinical trial coverage is mandated. So that's
we'll see how that goes.
I've never
We'll see how that
understood,
goes.
you know, again, having run national coverage policy,
Right.
what the big deal about that was, anyway, that's number 6 for the session. So Nancy, we're going to let you close on the issue about, you know, PF interacts, has tons of data about processes and decisions from managed care companies across the United States, now globally, health insurance perspectives. What's your view? I mean, do you think, and should, as John raised the issue, should there be this consideration of, you know what, I want that process to be something I can live with myself personally?
So I think for every patient, bar none, that we have ever helped at Patient Advocate Foundation, the goal they all have is that the physician treating them and the health plan through which they're insured is going to consider what is in the best interest for them. What we see every single day is that is the attitude of the physician, that our insurer friends are at a more distant place. Some of our insurance friends are very compassionate, Bill, and we see them establishing coverage criteria processes that allow you for easy appeals process, expedited answers. Those that are beginning to encumber us with more pre-authorizations are just slowing up the process. They're adding cost to the system. So from our point of view, what we see is an insurance industry that is now under fire to try to bring 32 million additional uninsureds into the marketplace through the marketplaces and exchanges, which is going to have an impact and is already having an impact on existing health plans and benefits that are being offered. So the short answer to your question is our patients pray that health plans will look at them as individuals, but they certainly acknowledge that they're being treated as an actuarial entity within their plan.
Great, thank you. So are there any questions out there? Just yell out, because I can't see. Any questions or comments out there?
Yeah. Bill,
John,
while we're
please,
waiting for questions, I think fundamentally, I would add a number 8 is
Gotta get to 10.
Evidence is your best friend, and we would never create a policy that we couldn't defend in court amongst our peers or amongst our families. So while we do have lots of prior authorizations in place, I would argue that we're ready to defend those based on the peer-reviewed evidence that's available in the literature, and including from NCCN.
Yeah. So do you believe in promising categories? Seriously.
Well, I think we believe in promising categories and encouraging enrollment in clinical trials. melanoma is a perfect example of dramatic transformations. We've had 4 drugs approved in the last couple of years, and maybe this year we'll have PD-1s and PDL-1s approved, and dramatic changes. And I think when there's evidence that those provide benefit to patients, we'll cover those. But we want to make sure that they're the appropriate patient for those, and they're most likely to benefit. And that's why we put the prior authorization process in place, because if we provide a $100,000 a year drug for somebody who doesn't have a V600E mutation and a melanoma, we've just spent $100,000 with a little likelihood of benefit. In fact, likelihood of harm.
All right, thank you. I see, I want to be on the panel next time, actually. I see a shadow out there.
So thanks for the panel. It's a really interesting discussion. One of the dynamics that's really playing out rapidly outside of even things like medical homes is the dramatic increase in out-of-pocket costs for patients. And particularly as employers are shifting from defined benefit to defined contribution, it's likely that these things are going to increase. And you pointed things like Walgreens shifting their entire employee base into private exchanges. So in a way, I'm just, it often strikes me that a lot of these conversations are going to become very acute very quickly. So I was just wondering what your thoughts were on that shift in terms of the out-of-pocket costs.
Well, I'll talk about this because it's an issue that we have fought for in the state of Maryland regarding oral chemotherapy parity. As you probably know, that upwards of a third of chemotherapy now will be oral, and that's a growing number. As you know, in most insurance plans, there's a sort of disparity between the way IV chemotherapy is covered versus oral. And in Maryland, we have passed a bill for the state written programs, and now trying to get it for the exchange written programs, where at least oral chemotherapy is being covered at the same way in which IV chemotherapy is being covered. It still generates quite a bit of cost to the patient, but at least we're trying to get some parity about that one particular issue. So this is a big issue with our patients. And then the other thing I'll say is with regard to these the drugs that are covered when patients don't have the money for their co-pays or have these big deductibles, our staff is inordinate amounts of time, our staff spending time trying to get various foundations to pay for money, pay for these co-pays. Certain organizations like the Leukemia Lymphoma Foundation, their money for the year ran out in mid-February for assisting patients for leukemia lymphoma related drugs. So this is an acute problem, and as the cost of the drugs have become ridiculous in terms of what a patient can pay for, and maybe ridiculous for what an insurance company can pay for, but it's kind of like, what are we to do?
Nancy?
And so I think my answer to the question is certainly we have joined efforts in Maryland to deal with the oral IV parity legislation, as well as 27 additional states in the United States. So trying to get a level playing field in that area is helpful. At Patient Advocate Foundation, we have the second oldest copay relief program in the United States and the third largest copay program in the United States. And to your point, Dr. Solano, there is just an endless vacuum of need for which there is insufficient dollars. And Bill, one of the things I think that would be important to this audience is around the issue of value. I think a lot of doctors are still trying to make improvements in practices in hospitals to add value. We have collaborated now with providers, pharmaceutical, biotechnology, nonprofit groups in the country, and on June 3rd, we'll introduce in the country the first consumer-based cancer care value index, which doctors will be able to use with their patients, so patients can complete a very quick survey to see this is where I saw value in the whole treatment experience. And by doing that, we can begin to work together to bend the cost curve and allow each of you in this audience to see perhaps an improved perspective on how you're going to handle these difficult cases.
I have a different perspective on this because nobody asked to get cancer, but likewise, nobody asked to get hepatitis C, nobody asked to get rheumatoid arthritis, nobody asked to get Crohn's disease, and yet there is no parity bill out there that says, patients with who take a sub-Q rheumatoid arthritis drug should get parity. And I think the dilemma is that all these drugs cost an extraordinary amount of money, and employers, to maintain not only be competitive locally and nationally, but internationally, have had to pass these costs on. So it's tragic, I think, that patients are having to make decisions about their care and their livelihoods because of cost, and yet that's the reality we face because these are extraordinarily expensive therapies. And I'm grateful that there are foundations that can help underwrite the cost of these, but this isn't a problem that's exclusive to cancer alone.
That's why I say there's no health insurance anymore. But one quick question back there, and we're going to get one quick answer, then we're going to close.
I'm not sure the question is quick or the answer is quick. The health technology assessment panels that advise Medicare on whether or not to cover new technologies are explicitly prohibited from considering cost. Do you think that prohibition should continue, should be modified, or should be eliminated?
I'm going to let Nancy answer from a patient perspective. That's the most important perspective. So Nancy, quick answer, please.
Patient simply wants to know, will there be value add to their life and extension to their life if this new device and this new process is going to come into the market?
Great. Well, this has been a terrific panel here. I have one closing statement that thankfully you'll appreciate. It is not from me. But actually, I use this quote a lot when I give presentations. And especially every year, for example, I lecture at the business school at Dartmouth. And, you know, you get all these 28-year-olds really super smart. They've had 3 or 4 years experience in the world, specifically. Actually, I said that positively, actually. Well, just a comment. I mean, it's better than a lot of people like the architects of the healthcare system. You can cut that one out, Christian, when you get to that. But anyway, but a quote from Lewis Thomas. You know, you may remember an oncologist, president of Memorial Sloan Kettering, sometime philosopher, sometime policy maker or supporter, and like us all, at some point, a patient. And upon getting this cardiac pacemaker, I have this longer quote, but I won't bore you with the whole thing. But this is about 6 sentences, so bear with me. But it's really indicative of the situation. So he's just gotten his pacemaker a few months before. And he talks about it ticking away flawlessly, soundlessly, the hands of my surgeons, you know, a miracle worker. And he says, I suppose I should be feeling guilty about this. In a way I do, because I have written and lectured in the past about medicine's excessive dependence on technology in general and the resultant escalation in the cost of healthcare. I have been critical of what I call halfway technologies designed to shore things up and to help keep flawed organs functioning way beyond their appointed time. And here I am, enjoying precisely this sort of technology, eating my own words. So, thank you very much. I hope it was informative, a little entertaining. Thank you to the panel. Very good.
Thank you, Bill.
Good job, man.
Very nice.
Yeah.